Okay, if you could all take your seats, and if you could sit at the table you were sitting at for the last exercise, that would be ideal. Thank you. Rather than the one time we don't switch today, I'm afraid. Yeah, stay where you are, please. Oh, from the previous exercise, because we're like expanding on what we did then. It'll all make sense in just a second. Sorry to keep moving, everyone. Right, I think everyone's largely back in their seats, so we'll now focus on the last exercise of today, which is expanding on the use cases, so really adding flesh to the bones of those use cases we have just surfaced, and to do that we'll do it through the medium of the UK's favourite venture capital-based light entertainment show, and that'll be Dragon's Den. So the Dragons would like to invest in linking sensitive data to realise the use cases you've just identified, but the case does need to be made. So based on your voting, you should now have a preferred use case on your table, which you will take forward for this exercise. Or if you have a couple with the same number of votes, you pick your favourite, and you'll now have to make the case for investment. So what we'll ask you to do, we're going to give you 20 minutes to prepare an elevator pitch, basically explaining your use case and the value it will deliver to the public. We will provide you with a template to help guide your thinking, and we ask that your thoughts are recorded on this. But there's a few things the Dragons would like to know. So what data you'll be linking, what research you'll be doing and what you're trying to understand, what are the potential outcomes and what problem you are trying to solve, what impact this research will have on the public, and how will it benefit society, and anything else you can think of. I should reveal you are also the Dragons as well as the pitchers, so you will be voting on each other's at the end. So for the purpose of our voting poll, we do ask that you sort of give your use case a 3-word summary to make the polling easily identifiable and recordable. And after 20 minutes, you'll make the case to the team. So we will do a round of presentations, and all we ask for is that you listen intently and are ready to vote on what use case you think will deliver the most benefit to the public. Before I circulate the template that we'll be working on, are there any questions relating to how this exercise will run or sort of what you need to do? I should make clear that the presentation is very informal, so please don't worry.
Right, dragons. We will, as a team, address one of the biggest challenges facing our NHS in its 75 years old history: waiting times. Who of sitting people here, you dragons really, have to wait for the NHS appointments? How long does it take actually to see GP? How long does it wait for the urgent cares and referrals to be actually seen in the clinics? The long waiting times. And this piece of work is going to help to resolve it and make the change different and make the NHS back to as planned to be. So what we're going to do, we're going to link the data, and we're going to need access to a number of the patient data, GP data, hospital data, especially around the referral times, treatment types, demographics, disease prevalence, elective care, emergency care, individual level medical histories, severity prognosis, waiting lists, and access to GP appointments. And really what we're going to do with it is to link to employment data as well. So what we'll be interested in is the benefit data, disability data. So in the terms what we're going to really come out with it is really going to understand the causes of the long waiting lists. Why this is really happening? Why do we have those bottlenecks in the system? What is stopping for patients to be seen on time in those 14 days waiting time, for example, the urgent cancer referrals? And we're really going to understand the impact of the long waiting lists of the general population health and employment at the same time. So let's have a look and a little bit think about the research outcomes and problem that's being solved. Well, first of all, it's going to reduce the waiting list. It's going to provide quicker time to diagnosis and to the treatment. Two separate things, very important here. It's going to as well offer more efficient resource allocation for the NHS, which is a big issue where we should put resources in terms of the staff and the finances which are currently available. So thinking now about the impact upon the public and the benefit to society. Well, first of all, the patients is going to offer the better health and the longer life, so putting their well-being. It's going to have an impact on the staff. if the patients have the better care, that means that we improve the well-being of the staff, and we can ensure the higher retention levels, because quite often our staff are leaving, so that's the important to ensure efficient healthcare. And the big one, a system change. So a system change is in the terms of the NHS, who ensure is much more efficient in the system, how we're going to allocate the resources, how our healthcare is being run, but also system change in the terms of the employment data. So if we can improve the waiting times, we can improve productivity. If people can go back into employment much quicker, it means we can keep people in the jobs. We can ensure they're not sick, so they don't access the benefits. So have a really big change sorting this one issue. So please, Dragons, make sure you have your cash there available and put it for this project. Thank you so much.
Thank you, Piotr. Just a reminder, you are all dragons, so please keep in the front of your minds all these use cases as we move forward. Thank you very much. That was fantastic. So on to table 2, please. Can I ask for a representative?
So, this is about the children in our society, the youngest of our society. We know that the biggest driver of child health in the early years is the home environment. It's where they live, it's where they walk around, it's where they go to nursery, and crucially, it's who they live with and how those people look after them. We know at the moment quite a lot about what's going on with mums and how that interacts with what's going on for children in their lives. Big gap for dads in terms of data. We know they're important. We can't measure how much or how they're important for child health. So that's really the area that we wanted to focus on, thinking about families and using families as the unit of measurement for thinking about child health and wider family health. 2 types of families, so biological families, but also social families. So really trying to take account of the fact that we have quite diverse household composition now. We might have 1 parent, 2 parents, more parents but not necessarily living together, or carers that aren't biologically related to the child. So we took the example of, this could work for lots of things, we took the example of childhood obesity, sort of up to at age 5 and above. And really thinking about how we might use data to generate understandings to break the cycle of obesity and unhealthy weight in our youngest children. So we would like to use data linked crucially for households, families, biological families and social families. We didn't completely bottom out what we wanted to be linked, but it would include, contacts, administrative data on contacts with services. So looking at mum, so thinking of the biological family, mum, dad, child, siblings, from birth of the child, and historically for the parents, across health, education, social care, family justice. Also, you could be connected to cohort and survey data. We also touched on, perhaps we could get commercial data on shopping habits and things like that, thinking about a child healthy weight. So we would use that data to look at the patterning, so the clustering of familial, genetic and social factors that contribute to childhood weight, unhealthy weight. And we could also measure spillover effects. So if you were to model if you were to intervene on one member of the household, the benefits it might have for the others, to make a case for prevention and taking a family approach. So this would, obesity has very long-term consequences across the whole life course, and it places great demand on the NHS. So potentially, by being able to develop interventions and target interventions for that within family units, we'd be able to reduce health spend, reduce morbidity, increase productivity. If we wanted to sell it to the government, we might say that. And also the moral argument of better individual health.
Thank you very much. So if I could now ask Team 3 a representative from. I can get that out of your way slightly. That might make it easier.
Okay, so our team, three words: better outcomes now, alternatively fund us now. So you'll probably remember us, okay? We talked about unmet need within the NHS, and I don't really need to say very much more than that. You're all very aware that the NHS has, the demand on the NHS outstrips its capacity and its ability to meet that. So that's what we want to tackle. The data being linked, we want to link healthcare utilisation, so how people are utilising the services, what appointments people are having, who's going in, when are they going in, how often they are going in, all of those that set of data. We want to link it to employment status, and we want to link it to education status. And we want to combine all of those things with interaction terms as well, to understand how how those different aspects have an impact on healthcare outcomes. And we don't want to just do the regular healthcare outcomes, which is how we start thinking, because they're the ones we're used to seeing, which are things like, if you want to think about anxiety, you say, what are the levels of prescription? We want to actually really know whether people are anxious or not whether they're prescribed anti-anxiety medications. So we might use wearables for that, and other sources of data that really get to the bottom of how well people are living. So we want to interact all these things, and that's what we're trying to optimise. We're trying to optimise, basically, solutions that make things better, but for everybody, not just one set of society. So we want to, in this, deal with inequalities. So we're looking to understand those sets of data, how they interact with each other, and how they impact on healthcare. So, for example, we think about things like GP. We all know it's difficult to get an appointment with a GP. There are some appointments in the evenings they're difficult to get hold of. None of you are allowed a GP's appointment in the evening because you are all able to rock up here for a day in London, which means actually you've got a pretty good lifestyle and you're probably going to be paid even if you do take time off in the day to go to the GP. So none of you are getting daytime appointments. The people getting, the evening appointments, the people getting the evening appointments are the people who aren't going to be paid if they don't turn up to work in the day. So those are the kind of optimisations we want to make for equality. Who are the worried well, going to the GP, chatting for ages with the GP, going away without anything, being an intervention because they're actually fine. They're not allowed to see the GP either. Who are the people who are the unworried sick? So the people who are, not going to the GP because they haven't got time, they're not sure. They're the people we want to try and get to the GP. So we're using all that information to optimise what we need to do to get everybody getting the healthcare they need, which will reduce healthcare utilisation and make it available to the people that need it. It's more capacity in the NHS for everybody. We know people have tried this with different solutions like chatbot, like Babylon, that didn't work. Probably Matt Hancock. NHS Informed didn't totally work. But anyway, all of this is going to mean everybody has better health. So fund us now.
Wonderful. Thank you very much. Moving quickly on to Group 4, wherever you are.
Thank you. Okay, so to start, if you felt like it was a really healthy process getting to this building today on your commute, raise your hand. Okay, so that's great. So who would like to see our cities be more healthy? Okay, so that's what we want to do in our project. So we want to understand what the impact of introducing low emission zones in cities is on health, wealth, air quality, and general mobility. And there's various data sources which are being generated all the time that would be really good for doing this. So things like, bike docking and scooter docking stations, seeing how people are moving in the city, ANPR data on car usage, air pollution data that's collected around the cities, electronic charge point data, we're seeing more electronic cars, sales of vehicles, weather data correlated with the behaviour data, transport information, wearable devices, and the list goes on until we get to things like the longer term outcomes around health outcome data. We've got data from HMRC, understanding the cost-benefit trade-offs of the impacts on health versus the potential negative impacts of implementing charges to get into these zones. We want to understand census information around the characteristics of people living in cities and how these clean air zones impact potentially different cities and different societies in different ways. Like what might work in London might not work in Bradford and so on. So we'll be able to understand the specific nuances of the populations living in the cities too. So we've got some short-term objectives where we can look at the changes of mobility almost immediately from implementation of these zones and the air quality in that short to medium term. And then longer-term ambitions to understand the impacts on health, on respiratory disease, on all types of different non-communicable diseases and things that are immediately impacted from outcomes of the pollution. So we are then working towards solving some of the biggest problems around climate change, the impact of various different diseases on health, the productivity. We can know that children are less productive in schools when they're living in higher pollution. So this is huge, tackling some of the biggest problems that we've got. And we can then impact society and be a benefit to the public by slowing down climate change and improving planetary health, but improving the health and well-being of all of us along the way as well. And we can see that there's some real kind of ways to actually not only evaluate what's happening, but implement further work through better urban planning within our cities. So yeah, thank you.
Wonderful, thank you very much. And now on to group 5.
So we are what we eat in a green and pleasant land. What do we want to achieve? We want to improve the evidence base which links multiple natural and social systems together, but considered through a food lens. What is grown, what is eaten, what is wasted, how much it costs, where it has come from. And we're going to look at all of this, as I said, through a food lens, but importantly, it will deliver routes to action which stop us thinking in silos, reduces the unintended consequences, and builds across multiple policy areas: health, well-being, environment, net zero, the circular economy, food security, national resilience, and so it goes on. How are we going to do this? Well, we have multiple data silos, and we need to bring them together and enhance them. The sorts of data silos that we have would be around consumer data, what's purchased, the quantity, the nutritional aspects, the waste, both at individual and household level. It would need to be longitudinal, and it would need to be considered seasonally. The provisioning services, the supply chains, the sources, the packaging, the embedded carbon. We are so busy, if you like, exporting our carbon elsewhere around the world. Time to actually look at it seriously. It covers transport, it covers waste. We want to know about food banks and food poverty, so the social aspects. And we need to then touch into land and agriculture and employment and all of the payments to farmers to enhance our natural environment. So back to our green and pleasant land, which is still delivering what we need. We need to know about income within our households, the social deprivation, the health of those households, because with all of this information brought together, we can drive those actions and give people the evidence and the information they need to make their own personal choices, but also as a nation to make choices.
Wonderful, thank you very much. We are now on to group 6.
Hello, everyone. So our team came up with an innovative, non-invasive diagnostic tool to improve colon cancer survival rate by early detection. So it's quite long. So, so today, 46 people in the UK die due to bowel cancer. And this is the 10% contribution to the total death of cancer. right? And the current process is, the endoscopist, they go through the videos. I mean, they go and check the frames, and then, they identify where they are the cancerous cell. And the studies has shown that 30% of the chance cases, the endoscopist miss those cancerous cells, like the polyps, they are known. Okay, so if we can detect these polyps early enough, the survival rate goes from 10 to 15% to 60 to 80%. So what we would like to do is we would like to use this data that we have, the colonoscopic data and their diagnostic. We would like to use as a primary data and develop an AI algorithm that can predict the cancerous cell or outline the, detect the cancerous cell. And also, we would like to link this data with individual health records and the ethnic information, lifestyles, and even the wearable data, right? And then the objective is to understand the effectiveness of this AI tool for early, improving the early detection of the cancer, right? So then the activities would involve, like, we take this data, then we train the model, and then definitely we evaluate on some kind of handle, this validation set, and then we will basically roll in a controlled, the environment. And we would like to do this study, like how does it impact the health services. If we manage to do, early detection, then we would like to see how does health services and status are affected. And also, we would like to say, like, if somebody gets recovered soon, then how does it impact the labor market and economy, right? And also what groups of people get benefited out of it. So the expectation from this outcome is that, early detection can, recover quick, and then we see, like, the contribution in the economy. And also, like, we aim to identify, like, certain giving up certain lifestyle change also prevent us from getting such cancer. So thank you very much. So we asked for 1 million for 2 years.
Wonderful. Thank you very much. We are now on to Group 7. Can I have a representative from Group 7, please?
Children's mental health. It's not just an agony for the people involved. It is a nexus for so many problems. So easily it spirals into long-term negative life consequences, whether it be recidivism and repeated crime, substance abuse, inability to find long-term employment. So what we want to do is bring together a wealth of data, personal data, for example, internet service usage, to identify potential risk patterns, potential predictors, with a whole wealth of public sector and services data, education, criminal justice, mental health and social services, both on an individual level, identifying what interventions work for which diagnoses, but also on an operational level, what treatments work, where are there problems in public services, what stops us from making these services better. If you can bring all that together, you can identify the risk factors and you can identify the best solutions, which doesn't just mean you're going to avoid applying the wrong solution, but crucially, it means you can have that holy grail in government, an integrated preventative approach. Deal with the problem when it's small before it spirals into these long-term outcomes. If you can do that, if you can stop the problem when it's small, that's going to be great for life outcomes. But more importantly, it saves money. Because if you couldn't guess from the self-important attitude and the posh voice and the sodding waistcoat, I work for Her Majesty's government. So I can tell you, nothing happens without a good business case for Treasury. We identify what solutions work, we stop spending money on the bad ones. Even better, if we deal with these problems early, we're not spending the huge amounts of money when the problems get bigger. Less money on prisons, less money on crisis services, less money on emergency housing accommodation, because people are leading productive, stable, employed lives. In other words, joining up with this data to find the effective solutions and answer these research questions is not just good for people's lives, it's good business. Thank you, Dragons.
Thank you very much. On to Group 8, please. There we are. See you coming.
Thank you. So our group want to talk to you about enhancing domestic abuse interventions. And over the last 100 years, we've really come leaps and bounds from a situation where domestic abuse was something behind closed doors, that was very much a private matter. And now we've got a shiny new legislation which really recognises that children, even if they're not on the receiving end, they're still witnessing that abuse, and that has an impact on them. What's the evidence there? Well, very much the evidence that has been building up over the years has been qualitative, and we'd like to have some quantitative evidence for it, something much more solid, which is why we'd like to link a lot of data sets. We'd like to see the whole journey for families through this system. So we'd like some police data to see when there are reports, and we'd like to see when that escalates into the courts, into the family courts to get some protection against the abuse, and into the criminal courts because those protections have been breached and there now needs to be restraining orders. But then what we want to know is for those families and specifically for those children, what are the outcomes of this? So we'd want to link to health data, so that could be GP data, hospital data, obviously accidents and emergencies data, maybe some pharmacy data, some local authority data to see about which children are ending up in the care system, deprivation data, maybe some education data, some census data to have a sense of how the family is composed and how people move to live with different people. So what's the objective? To look at outcomes related to that court journey and related to the domestic abuse, and really to have that longitudinal study to understand what the outcomes are specifically for the children. What are the benefits of that? Well, there would be, first of all, some feedback to the judiciary to tell them when you make those types of decisions, this is having those types of consequences on children's lives. We also want to know about better decision-making to support and resource domestic abuse services, design interventions to prevent the abuse, better social care information and knowledge for the healthcare system, and also hopefully fewer people going to court, returning to court, because the decisions that were made initially were better decisions. And if fewer people are returning to court, that frees up resources for the people who do need to go to court to be seen earlier and heard earlier. Thank you.
And that brings us on to Group 9, please.
During the pandemic, 90% of adults had at least one vaccination, and 80% had 2 or more doses. Now that's quite amazing. Yet this means that 10% of over 60 million people had none, and 20% of people didn't have a therapeutic dose, which left them 2.5 times more likely to die. Our aim is to understand the factors that influence the uptake of vaccines, especially those things that are modifiable. So we're looking to link diverse data in a trusted way. We're going to start with vaccination uptake, which you know has been centralised and is available to you via the NHS app. We're also going to link other health data. We need to know about the waves of the pandemic. We need to know about people's health conditions, their medications, things like demographics, ethnicity and socioeconomic status. We want to understand people's interactions with the healthcare services. But then we need to know some things beyond healthcare. We need to understand their access to vaccination centres, their geography, the transport that can get them to that centre. We're interested in public communications. What was the government's communication through the pandemic? What was the wording of those messages? What was broadcast via television? What was published in print media? What was the sentiment of that information that is publicly visible? What was communicated locally? Were people trained locally to message? And then importantly, what was the social media posts around this? We know that can significantly influence people's decisions, and how was that shared? So what? Why does this matter? What can we do with this? Well, we can influence policy for future pandemics. That includes health policy, such as how would you roll out vaccination centres. It will inform how we set up data systems and the accessibility of data. Secondly, it will give us learning about optimal messaging around public health and vaccinations, and specifically how we target messages to particular communities. Thirdly, and probably most importantly, it helps improve the health outcomes for everyone in the country, such as avoiding death and reducing pressure on the NHS. And to finish with our really quick win, we want to review the accountability and policies of social media companies. Please invest in the anti-vaxxers.
Thank you very much. I think that brings us to the end, and that's all 9 groups. Please shout if not. I'm glad I'm not a dragon who has to pick between them, as they were all fantastic. I'll now hand over to Katie to take us through sort of a little voting system.
All right, as if by magic, we have created a Menti poll based on the pictures that you have. If you didn't kind of have a catchy brand name, I've just tried to summarise it, so I hope that's okay. If you can go onto your devices and go on menti.com, please, and if you don't, kind of wave one of us over and you can use our devices. And there is just a code on the top for you to kind of enter this poll, so I'll just give you a minute to get sorted.
I'll read the code out for all those who are waiting. It is 27603783, and I'll just repeat that in a couple of seconds. That is 27603783. Those are your winning numbers. Does anyone need the code again?
Okay, I can see we've had 35 voters so far, and we're expecting probably over 50. So it's still all to play for. Okay, I can see 1 or 2 more people still tapping away. Okay, are we done? All right, okay, that is it. So we are what we eat have just pipped it by 1 vote. So a big round of applause to you. But also a really great spread of votes across the board. So well done, everyone, for your fantastic presentations. That is it from me and my colleagues for now. We do just have a few closing remarks from our dear colleagues.
Just to get everyone going to drinks, I guess. Yeah, so I think the first thing to say is thank you very much. I have to say, we are what we eat. I mean, I thought that was an inspired title. I really like that. I also love the little NHS waiting times picture. I'm not sure who found that, but that little picture of the little boy is, I like that one a lot as well. Again, so just to close off, thank you very much. Again, as I said this morning, you know, it's a big time commitment, a day out of all your busy work to be with us here, and essentially, you know, you're supporting us in steering the direction of the program. So a big thank you to all of you. We really appreciate the time that you've given us today. In terms of next steps, just touching on those briefly. So we will have sort of an online plenary session on Monday the 11th of March, and that's really a playback. You know, we've got now the job of writing up and making sense of everything that we've worked on today. So we're going to be playing that back to all of you, or those who can join, to sort of see, does that resonate, have we missed things? So that's happening on the 11th of March, so please join if you can for that. As I mentioned this morning, there will be a report that will come out of this. And most importantly, then the final point is really that this is informing the directions of the next phase of the program and the next phase of Dare UK. As I've sort of said this morning, we're going through the process there, so more in that when we can talk about it. I think that's really it. I think there's one more slide, which is again just, yeah, thanks. If you do want to sign up to the newsletter, if you do want to connect with us, it's all up there. We do try to send out monthly newsletters with everything that's happening. And finally, we do have, I'm not sure where exactly, I'm looking for Ballant here, if it's downstairs or across. Yeah, we do have drinks. Oh, you're going to come in. Okay, so we do have sort of a little networking session afterwards. From my side, again, thank you so much. Really appreciate the time from all of you. And I hope it certainly won't be the last conversation that we have as Dare moves forward. So fantastic, thank you.